So, good afternoon, everyone. Myself, Dr. Sonal Mehta from Intas Pharma. I am lead medical advisor Intas. Being a knowledge partner, this time Intas Women Health Team, headed by Mr. Satpathy, has brought webinar on role of testosterone in poor responder. I am glad to welcome you all to this webinar given by our eminent faculty, Dr. Sunil Jindal. Dr. Sunil Jindal, MS, DNB, MNMS. He is the scientific director of Dr. Madhu Jindal Memorial Test Tube Baby Center, Meerut, Vice President Delhi ISAR, Delhi IAGE. He has to his credit more than 75 awards from different organizations, and he has published many book chapters and many publications, over 200 national and international presentations, and his special interest is ART, laparoscopic surgery, and medical and laboratory andrology. So with this, I welcome Dr. Sunil Jindal. Over to you, sir.
Thank you very much, Dr. Sonal. And once again, as far as testosterone is concerned, we would go ahead and talk about the way testosterone functions. It's very interesting that one of the most challenging part of ART is poor responders and azoospermia. So any place where you do not have the gametes of good quality and very less in number, that is the area where the challenge comes in. And let me be honest with you, my idea is very simple. Say no to third-party reproduction. And this is the area where testosterone comes in. You'll be surprised to know that though this is a male hormone, the role of this in the primordial follicle development is so high that this is used in poor responders. We need to understand that to give a baby to a human being who doesn't have sperms or who has been told that you cannot make eggs is the challenging and the most beautiful area. So I would today present to you the way testosterone is to be used in poor responders and how to go about using it, the method for it. There is only one thing which I would show to you on the video before I start on. And I will tell you the exact method which is to be used and the way we use it. We will also show you the results the way they are internationally. And recently, a patient of ours had given birth to a baby, poor responder. First cycle when we tried, we just got about 3 oocytes, made 2 embryos, didn't get pregnant. And the next time when we tried, we used testosterone, and now she has a beautiful baby with her. So her experience I'd like to share with you for you to really understand. And I do not say it's a magic drug, but out of all that is available to us, this has been useful. So let me start the presentation now. So I would like to talk to you about the role of testosterone in poor responders. And the sadness of a poor responder, we all of us know, and a woman who is told that you cannot make eggs. The first question which she always says is there any medicine you can give to me to make my eggs again? And well, you could try this. So the way I have tried to make this presentation is by giving a short introduction, by telling you about the androgen in female physiology and infertility, telling you about testosterone in poor responders, bringing across to you some clinical evidence, and then summarizing the way everything is. Now, poor responders. This represents a significant portion of women and is about 9 to 24%. So all those people who come to us for IVF, about 9 to 24% of these are poor responders. And a lot of time people go in for third party, but a large percentage of these patients can have babies with their own oocytes. Now, despite the advancement, whenever poor response comes in, it is challenging, as I had mentioned to you earlier. Now, what is the definition? As per 2011 ESHRE Bologna criteria, at least two of the three features must be present. Either an advanced maternal age more than 40, a previous poor ovarian response, cycles cancelled or less than through oocytes on a conventional protocol, an abnormal ovarian reserve with a poor antral follicle count, and a poor anti-Mullerian hormone. Now, I was just wanting to bring in this slide to you for you to understand how folliculogenesis is there in primates. So the cycle is about 120 days. And in this 120-day cycle, there is only the 14-day cycle which is gonadotrophin dependent, which means from the time of the antral follicles till the time of the ovulation. And the rest of the time, what we actually have is a time where there is a primordial follicle, primary oocytes, secondary oocytes, and this paracrine time is gonadotrophin independent. However, I will talk of what it is dependent on. So let us look at this slide for us to understand what is the impact of maternal age on oocyte and embryo competence. So now what happens is that whenever you have a woman and the ovarian age is increasing, you have a reduction in the ovarian reserve. But you also have a reduction in the quality of the oocyte. And in turn, it also leads to a poorer embryo quality. So for us to understand, one thing is very clear, that there is just not an impact on the maternal age, on the oocyte number, but also on the quality and also on the embryo competence. Now, how does the number go on? So we need to understand that at birth, there are about 10 lakh follicles. And this goes on to about 6 lakhs. And what normally happens because of this is that as the number goes down, which goes to around the end of fertility, where it is about only 1 lakh left. So this is age dependent. And do we all know that there are only 600 ovulation cycles which a woman has in her lifetime. Now, what is the relationship between age and a poor ovarian reserve? So if we look at the graph, we realize that as age increases, so do the cancellation rates of the cycles increase. And similarly, as age increases, you also have a condition in which less than 4 oocytes are procured. In any advanced age, there could be no ovarian reserve, which means there is no benefit of stimulation. There could be AFCs less than 3, which means low oocyte yield irrespective of any protocol you use. There could be a very high FSH level. So if the FSH is more than 11, you become very cautious whether you would like to take this patient up or not. But above 15 FSH, there really are very hardly any ovarian reserves left. So the functional ovarian reserve is a key criteria to consider treatment. Now, how can the male hormone androgen be used to overcome ovarian aging. So the role of androgen in folliculogenesis and in steroidogenesis is very important. And there is evidence from animal studies, from human studies, but of course, we need more evidence. So at this moment, I would like to bring to you what do we know, how can we use it, what are the results, and what we need to do in the future, and what is being done in the future. So now, in a woman, androgen plays a key role in the physiological control of ovarian function and acts both as a precursor for estrogen biosynthesis and directly via the ovarian androgen receptors. So it is not only on the biosynthesis, the way estrogen is made, but also it acts on the ovarian androgen receptors. So now if we look at the pathways of androgen, the first pathway is the one which is there in the adrenaline. So cholesterol changes to DHEA. And the other one we have where it is in the ovary, where it starts from progestogen and goes on to become androstenedione, which further on becomes testosterone. And apart from that, of course, there is a link between the two, but these are all independent pathways. Now, if there are inadequate level of endogenous androgens, it is associated with decreased ovarian sensitivity to FSH and low pregnancy rates after IVF. So therefore, endogenous androgens need to be adequate. Now, this is a pattern of androgen expression and the impact of androgen exposure on ovarian dynamics at the different stages of follicular development. So when you have the primordial or the preantral follicles, androgen stimulates the transition of primary to secondary follicles. Then when you get the preantral and the antral follicles, it has an action on the follicular stimulative hormone receptors. So what the testosterone does is it increases the receptors and it increases the granulosa and thick cell IGF-1 and IGF-2. And in the antral and the pre-ovulatory, it increases the follicular population. So what happens is that in patients who are poor responders, when they are given testosterone, it has a direct effect in which it increases the antral as well as the pre-ovulatory follicular population. And what it does is it decreases the presence of apoptotic granulosa cells and follicular atresia. So you have a larger number of follicles which you get, which can be stimulated. Now, another thing which happens is that it improves the ovarian response in superovulation, and you have better oocytes in a larger number. So this is one slide which could explain to us a lot of things the way androgen would be functioning. This is the animal model, and in the animal model they felt that the AR receptor or the androgen receptor leads to action on antral development, maturation, and not only on the ovulation but even the luteinization. And therefore, the whole cycle is in a way not only estrogen dependent but also androgen dependent. So the androgen has a direct action by the androgen receptors, and it has an indirect action where it gets converted to estrogen and on the estrogen receptors. So there are two ways in which the mechanism of androgen action happens. Now, what is the impact of androgens on fertility, physiological, clinical, and therapeutic? So ovarian androgen synthesis and regulation is essential to ensure adequate steroidogenesis and folliculogenesis. And in primates, there is evidence that the number of follicles and the process is governed by it. And in infertile women, androgen at times needs to be assessed. Now, a lot of times what happens is you have polycystic ovaries. So you drill polycystic ovaries. You realize that the decrease of ovarian androgen leads to a decreased risk of hyperstimulation. And ovarian androgen supplementation is considered in women who have low ovarian response to gonadotropins, or if they have an androgen deficiency. So on the whole, we have understood the role of androgen. The androgen enhances the function of the FSH we are giving. And in case the androgen is less, the folliculogenesis and the antral follicle count would be low. A couple of studies. So in 2009, there was a study in which they took patients of previously cancelled cycles due to poor response. And they had two groups. One group was where testosterone 2.5 milligram was given with the same FSH dose. And in the second group, they gave 600 international units of FSH or HMG. And the cancellation would be if they were less than 3 follicles, or the follicle was less than 14 millimeter. So it was found that the cycles with low response was significantly lower in the first group. So increasing the FSH was not the answer. The answer in this study was giving androgen. So pre-treatment with transdermal testosterone may improve ovarian sensitivity to FSH and follicular response to gonadotropin treatment in previously failed or cancelled cycles. Another study which I'd like to talk to you about, which is a 2014 study, that low testosterone levels in women with diminished ovarian reserve impair embryo implantation rate. This was a retrospective case-controlled study. So what they did with this, that in 223 patients where IVF cycles had been done, they studied these and they found that in women with DOR, the basal testosterone present in had a positive association with the pregnancy outcome in IVF. So poor reproductive outcomes were seen in women who had a low basal testosterone. So they found out that, well, there is a correlation in the patients who have a poor implantation where the testosterone is low. Then what is the rationale? Androgen excess has been shown to stimulate early stages of follicular growth and increase the number of preantral and antral follicles. This we had discussed below of why does it happen. And intra-ovarian concentration of androgen augments FSH receptor expression in granulosa cells, and it leads to better response to FSH. So somebody who was not responding to FSH, 300 IU or 450 IU, when you give these patients testosterone gel, I'll tell you how it is given, they start responding. So that is an area where it can be used. So testosterone gel pre-treatment for 3 to 4 weeks increases AFCs and ovarian blood flow. This has also been found, and potentially improving ovarian response to controlled ovarian stimulation and IVF outcomes in poor responders. For this, testosterone can be used. So this is a study of human reproduction, update, 2012. And they studied the use of androgen and androgen modulating agents in poor responders undergoing in vitro fertilization. And in this, they come up with the conclusion. It's a very long study. I could go in and explain to you the whole study, but I'll give you the nutshell of this. It came up with that based on the limited available evidence which we have, transdermal testosterone pretreatment seems to increase clinical pregnancy and live birth rates in poor responders undergoing ovarian stimulation in IVF. And they also came up with different other agents and the modulating agents like DHEA, HCG, because see, we have to understand two things, that apart from this, DHEA has been used, in which a pre-treatment of 2 months has been given. Recombinant LH has been used. HCG has been used. Letrozole has been used. And in this study, they found that there was insufficient data to support the probability of an enhancement of pregnancy in poor responders if we gave all these products. So in 2 trials which were involving 163 patients, pre-treatment with transdermal testosterone was done, and they found that there was an increase in pregnancy rate and in the live birth rate. And there was no significant difference in clinical pregnancy rate and live birth rate in patients who got DHEA. And the reason is that DHEA per se on itself is not the active product. The active product for this is actually testosterone. And this was given with the idea that, well, it is going to get converted into testosterone, but that is not the way it actually would be clinically. And similarly, they found out that if you added recombinant LH, there were studies to prove that it did not have any increase in pregnancy rates. And well, in our patients, we have tried everything. We have tried putting these patients instead of HMG into recombinant, high dose recombinants. We found there was not much of a difference. We started giving higher doses about 5 years back, 6 years back. There was a time when we used to give about 450 international units, and in a few patients we went up to about 602, but there was no difference. We realized that if the hormone is good and if you give 300 or 375 international units, well, that's the maximum that you could give, and that's the maximum which would have its results. What probably you would need to add is something else, or you would have to try another cycle the way it was. So now the duration and dose of testosterone. In Reproductive Sciences 2016, Polizos came up with the study the way it has been done. And it had been given for 21 days, 5 days, and 15 days. And the doses normally were 10 milligram to 12.5 milligram, which is normally equal to 1 actuation of androgens. 1 actuation of the gel which is available has about 12.5. So when we need to give this hormone or this gel, I normally would give this gel as a single actuation in the woman in the -1 cycle. At the time of stimulation, you don't give it. At the -1 cycle, starting from day 5 for 21 days. And how do you give it? You would take 1 single actuation and you would apply this on any area of the body, where you would apply this. But for a male, when you give it as a testosterone in hypogonadism, you need to take 4 actuations of this. So the dose for a woman is a single actuation, which is to be given from the day 5 to day 21 in the -1 cycle. And if you ask me honestly, this turns out to be very, very inexpensive compared to gonadotropin. So this is something which we have tried in the last 1.5 and 2 years, and where we use this for our poor responders. So now the question is, should I use this for 2 weeks, 3 weeks, or 4 weeks? So about 120 women were recruited into this study and randomized in control for 2 weeks, 3 weeks, and 4 weeks. And 12.5 was given, like this drug, daily for 2 weeks, 3 weeks, or 4 weeks. And it was found that the total dose of recombinant FSH administered for stimulation was significantly decreased in the 3 to 4 week treatment dose. So what we have been given till date is for 21 days. But we need to understand that the cycle of folliculogenesis dates back to previous to it, which is not gonadotrophin dependent, but it definitely is dependent on testosterone, which means the number of antral follicle counts I'm going to get may increase if I give it for a longer time. So now studies are on where this drug is given for a longer time, which I will talk to you about. Now, what is the effectiveness of transdermal testosterone gel for poor responders in IVF? So 2 groups were taken, and it was a randomized study. And group 1 included 55 patients. They were given 1% gel. And group 2 includes the remaining 55, which were not given androgen gel. And the dose again was 12.5 milligram of testosterone, started from day 6th of the previous cycle. And the patients were taken onto an antagonist protocol. So the number of oocytes retrieved, the number of embryos, pregnancy rate, embryo implantation rate of the group of patients using transdermal androgel before controlled ovarian stimulation was found higher than those of control group with statistical significance. So the use of androgel before stimulating ovarian can improve the responsiveness of poor responders when undergoing IVF. So, well, the effect of transdermal testosterone gel pre-treatment. In these, if 110 low responders were present, it was found that the results of this were better when they were given for 21 days. A lot of studies have been there, but 3 trials were included in one major systemic review and meta-analysis. And it was found that transdermal testosterone increased the live birth rate as well as it reduces the dose of FSH. In our experience, let me be honest, in poor responders, we did not reduce the dose of FSH because they already were poor responders. But in these patients in whom we had given testosterone, the number and quality of oocytes was enhanced, even if not very significantly in a few patients, but still they were enhanced. And we've had a few pregnancies in these patients in which previously we did not think that we would get pregnancies at all. So I would now talk to you about this patient of ours. She recently delivered. She was a poor responder. She had been told at a lot of places that, well, a donor egg needs to be used. So she came to us and she said that she doesn't want a donor egg. Her AMH was about 0.6. Her age was about 37 and her AFCs were about 4 to 5. So in the first cycle which she underwent, she developed about 3 oocytes, 2 embryos, did not get pregnant. Then in this patient, in the next cycle, she again said, I'm ready for another cycle. We explained to her that, well, we plan to give you testosterone. Testosterone is a male hormone, but this male hormone is a part of the hormone which makes the eggs. So if we try this, the chances may be better in the next cycle. And we gave her the next cycle. And in the next cycle, again, she had 4 oocytes, but good embryos. We transferred them. and she's just had a beautiful baby, and she wanted to give me this recording because she said that she wants to be an ambassador of hope for those women who want their own baby and somehow feel that it is not possible. So there's a very short clipping of hers. With your permission, I'd like to show her the way and what she says. And it's really touching, and it has been for us.
जब जैसे मैम ने मुझे पहली बार ही जब बोला कि डोनर एक्ट के लिए तो फिर थोड़ा मुझे डर लगा, लेकिन फिर सर मैम ने होप नहीं छोड़ी, बोला कि नहीं इसी पे ट्राई करेंगे और ये होगा, और ये हुआ। मेरे लोअर मैच पे डोनर एक्ट ना लेके मेरे अपने एक्ट से ट्राई किया, और सेकंड साइकिल पे मेरा ये अपने एक्ट से 14 साल बाद ये सब होना मेरे लिए बहुत बड़ी बात है।
So, why did I want to bring this to you? And why did I bring this video to you? Because, and it's not about the drug, it is about the fact that you and us work incessantly, read incessantly. Your being over here at this moment at 2 o'clock on a Saturday for this program proves that you want to add value to these people's life, because this is the biggest happiness for all of us. And this is the reason that I always believe that I should be in a position to actually bring forth to you useful things which you could use. So now we have in the future the ongoing T-transport trial in poor responders, and it's a double-blind, placebo-controlled, randomized control trial of a very large sample. And the aim of the trial is to test the effect of administration of transdermal testosterone for 2 months prior to ovarian stimulation using a long agonist protocol in line with previous work indicating that 2 months of androgen pre-treatment may equip pre-antral follicles with more FSH receptors and increase the cohort of follicles surviving to the recruitable antral stage. And the daily dose in this study of transdermal testosterone is 5.5 testosterone per day. So half of this. And this is a very large trial going on, very eagerly waiting for this trial. And if the results of this trial are favorable, I think there would be a very large number of patients which we ourselves would try. Because let me be honest with you, giving a third party has no challenge. But being able to give a poor responder or an azoospermic man their own child is priceless. So in summary, androgens synergistically with FSH enhance the sensitivity of granulosa cells to FSH, promote follicular growth and development. Clinical data reporting a beneficial effect of androgens or in augmenting IFF stimulation in women termed as poor responders has supported the adoption of this concept in many IVF clinics worldwide. Testosterone gel pre-treatment for 3 to 4 weeks helps us, helps the patients, gives rise to better oocytes, and decreases the dose of FSH, though we have never decreased the dose because they already are taking the highest dose possible, and that's what we would like to give. So I would thank you all for being here in the June afternoon for testosterone. So we've had a series of 4 lectures of testosterone, and this is the 4th. And the interesting thing is this 4th one is for women. And the 5th one and the final of the series is the role of testosterone in sexual dysfunction of men and women, which is very important because this single drug leads to enhancement in the sexual function of both of them. So thank you very much for being here. I love you all. And in the future, the next lecture, which will be next week, let's talk about the sexual dysfunction. Do be in definitely I would try to bring to you very useful things which you could use in your clinical practice. Thank you very much.
Giving us a very insightful lecture and giving a practical hints. There are some questions. They all have appreciated your lecture. Uh, Sir, almost many of their questions are have been answered in your lecture, but if they are asking, um, is there a role of testosterone in poor endometrium in donor cycle?
No, testosterone does not per se have any role in the endometrium per se. Its main role is in the folliculogenesis because of the androgen receptors and because it enhances and gives a difference. I mean, it enhances and acts as a catalyst to the FSH receptors.
Again, most of them are asking again to explain what is the dose and when to start and for how many days, whether it is 3 weeks, 4 weeks, 8 weeks.
Okay, now I'll tell you how I do it or how we do it. So I and my wife, Dr. Anshu, make a fantastic team. So she gives testosterone to the women, and I give testosterone to the men. But as far as this testosterone is understood, this is the vial which we use. And when we use this, what we do is we take the patient in the -1 cycle, which means in the -1 cycle, we start this gel as a single actuation, a single, I don't know if you know, a single pump. And we give this single pump starting from the 5th day to the 21st day. We could also give it from the 5th day for 3 weeks. And after we have given this for 2 to 3 weeks, we would stop it. And then we do not give testosterone during the stimulation cycle. That's how we normally would do it. Now, with the T-transport study going in, where they're giving half this dose and they're giving half this dose for 2 months, let us see the results of that. If the results of that study are good, then probably we would shift on to giving this for -1 and -2 cycles in half the dose. That's what we would plan, depending on the results of that study.
Right, sir. And they're asking, is there a difference between transdermal and oral testosterone?
No, you can't give oral for this. You cannot. The reason is that the oral testosterone has a lot of peaks. You do not know the quantity you are giving. You do not know the absorption. You do not know whether it would be regularly there in the bloodstream, because we want a regular bloodstream. In fact, let me be honest, in the males, because more studies have been done in the males, and in the males it has been found that the role of injectable is definitely not there because of the troughs and the peaks, and transdermal is better than oral. So it's more convenient, it is better, it remains as a single, I would say, plateau, and that's what has been studied.
Correct, sir. And they are asking brand name of the gel.
What I use is Androtas. It is Androtas. It is a testosterone 1% gel, and it is made by, well, if you give me the permission, I could say by Intas. But gel is also available in other doses. But the most important thing is that gel, otherwise, if I buy, like I use a lot of testosterone gel for male treatment, and the other companies don't give me in a 12.5 actuation. So what happens is if I cut it and I take it out, it would be more. So we would have to discard it. So in a 12.5 actuation, I get it normally from this pump.
Probably this has been answered. It is they're asking, is there a role of giving 12.5 mg of testosterone for 2 months?
Yeah, I've answered it. Not 12.5, because the new study which is coming up is 5.5, half of this. So let's see how the study is. In case there are better results of this, then we would start using it. Matlab, what I mean to say to you is, you have, what all can you do? You can increase the dose of the FSH, which has been proven that it doesn't give you better results. You could add recombinant LH. But well, once again, it has not been given better live births by large studies and meta-analysis now. DHEA, as it is, you would give for 2 months. And well, a lot of studies have brought out that it really does not give you the results as it should, because its conversion to testosterone doesn't take place. So the answer at the moment, what we have found, is giving these patients testosterone.
Sir, when to stop? Do we need to stop testosterone when we start the stimulation?
Yeah, you don't have to give testosterone with stimulation. You have to give it in the -1 cycle.
Right, sir. And again, there someone else is asking, can it be continued till trigger? No.
No, it is not to be given that way. See, let us understand. We are giving it in the paracrine phase, a phase which is not gonadotrophin dependent, because we want better AFCs. We want that the estrogen would work better and the receptors are better. So we would like to give it at a stage before the stimulation.
Sir, next question is, what if we started testosterone from day 5, but if the batch had to be postponed to about 7 to 10 days? Should testosterone be continued even if 3 to 4 weeks completed?
Can you repeat it, please?
Sir,
Please.
what if we started testosterone from day 5, but if the batch of IVF had to be postponed for about 7 to 10 days, should testosterone be continued in that patient even if 3 to 4 weeks completed?
Yes, see, you have to understand that normally we do not do these batches. So for us, what we would normally do is give them for 3 weeks, and after 3 weeks, get them onto an antagonist cycle. But in case it is so, you could give these patients for a longer period. Yes, you could. But during stimulation, you will not give them. I mean, during the cycle, you will not give them.
Yes. They are also asking, sir, apart from this webinar, they are asking, what are the tests for infertile men you practically do?
I've had a lecture before this. See, the thing is that whenever, and I try to give everything, but for infertile men, I mean, it's a whole lecture for per se for infertile men, and it'll be very difficult at this moment to go ahead, because with a semen analysis, I would like to get a hormonal profile done in a few patients. I would like to get an ultrasound done in a few patients. I would like to get a semen culture in a few patients. I would like to get specialized tests as horse test, and I would like to get a DNA fragmentation in a particular subset of patients. So I had a lecture of this earlier. So if you could go on to the YouTube and you go on to my channel, you probably, it is uploaded. So you could go through it and it is self-explanatory. Yes, it
Correct.
is. In fact, if you could WhatsApp on a number, any of you, if you want the recordings, they could send you the links, and the number would be, even this presentation, I could send it to you and the way you use it. So the number on which you need to WhatsApp is, just a minute, I'll just let you know. It is 800 6666 085. So if you WhatsApp on this, I'll send you the presentation on male fertility, and I'll repeat again, 800 6666 085. Prashant, can you please type it in the chat box? Prashant? Prashant?
Sir, I will type it. 800
I type it over 66
085.
So just
800 6666 085.
Yeah, just WhatsApp on this number, and I'll send you the presentation. So just go through it; it will help you. And the next program we have on sexual medicine, male and female sexual medicine and testosterone. So I mean, this single drug testosterone, we've had 5 presentations on this. So I mean, this drug is so important. So if you would be there, it will be very useful to you, because you'd be able to treat your patients and use testosterone gel, and be there for sure. We would love to have you with us.
One last question, sir. Why you don't give testosterone during menstruation? So that is,
I mean, I mean, I didn't really get it. We are
yes, sir.
using it. We are using testosterone over here in poor responders, and menstruation for it to come. I mean, probably she must have wanted to frame something else.
Right. Yeah, that's what. And they are thanking you, sir. Exactly when to stop testosterone, day one or day two of stimulation?
No, I told you, you would give the patient testosterone from day 5 of the previous cycle. You would go up to 21. Then the patient would get periods. You could continue it even, acha, you could continue it in menstruation also. I mean, you can, but you have to stop it at the time when you are starting stimulation. You can
Right, sir.
give this drug for 2 weeks, 3 weeks, or 4 weeks. 2 weeks, 3 weeks, or 4 weeks. And you can continue this from the day 5 till the day 21, or you could even continue it for another week. It's not a problem. But post menstruation, when you start stimulation, then you have to stop it. You could continue during menstruation.
And sir, what's the common complication of testosterone gel, or is there any side effect? That's what they're asking.
See, you're giving it in a very small quantity. So, per se, it will not give the androgenic features normally to a woman when you're giving it for 2 or 3 weeks. But yes, if you give 12.5 or more dosage to a woman for 2 to 3 months, it definitely is going to give rise to the androgenization. The pimples, the hair, and all those things may come up. So, the dose in a low dose, it normally does not have much of a side effect.
Right, sir. And sir, they all are telling good lecture, wonderful lecture. And one more last questions. In the stimulation cycle, many poor responders end up with the day two cyst, as we don't give estrogen or pill pre-treatment in previous cycle, as we are giving androgens. How to proceed? Meaning that there are two cysts, and when you are giving androgens, so how to proceed?
Cis you could have even otherwise. I mean, even with androgens or with and without androgens, you could have it either way. So if you have cis, even with androgens or without androgens, you proceed the way you normally would do.
Correct, sir. So there are many questions, but with this time limits, we are closing now. Thank you, sir, for very wonderful lecture and insightful lectures. And they are also they are telling you make presentation easier to understand. Thank you, sir, and thank
No,
you, Intas.
no. I'll tell you. No. I really will tell you. Our aim is to give you a presentation which you could use. To make this presentation or understand this, we must have read every paper available till date, every literature available till date. But by explaining you this data, it doesn't make me more intelligent. By actually being able to get the crux out of it and present it to you, for you to use it for your patients, makes us happy. And we feel that this is the reason and this is the way a new drug or a new methodology could be used. So I'm grateful to all of you for being here and taking time out. And it's been a pleasure interacting with you. Thank you very much.
Thank you, sir. Thank you, sir.